Now we have the second speaker, Dr. Anurag BADHANI, and he's going to talk on pre-nuclear emulsification PCR. How do I manage? He's a retina surgeon, but he's going to talk on a small talk on cataract.
Good morning, everyone. So
Dr.
in
Tamir,
this presentation, we will go through a series of videos, and here we will try to learn how to manage PCR in different situations. So PCR is a well-known complication of cataract surgery. It's a dreaded, potentially vision-threatening complication, and it may call for additional surgical procedures in the same sitting or in the next 1 or 2 sittings, and higher incidence of post-operative complications is also there associated with PCR, which may finally affect visual outcomes. So the strategy in such cases is mainly to recognize the tear as early as possible. There are some signs like sudden deepening of the anterior chamber, some sudden change in pupil size, especially during hydrodissection, which is called the snap sign, where there is pupil constriction, and abnormal tilting of the nucleus, abnormal behavior of the nucleus following the phacotip. These signs can help us recognize that there is a tear earlier, and in such cases then we should stop immediately. We should stop aspirating, and the phacoemulsification should also be stopped. We should continue irrigation in such cases and inject visco and form the anterior chamber immediately, and then stabilize the chamber and the tear by various techniques before it becomes larger and causes more complications. So this is a case of a mature hard cataract. While aspirating the final few fragments, we see that we have created inadvertently a posterior capsular tear. So here we immediately stop and put lots of visco, form the chamber, mainly to move the fragments away from the tear and push the vitreous back. Here we are attempting a posterior capsular excess to regularize the margins of the tear so that the tear does not extend towards the equator, and by completing the rexis, the implantation of IOL becomes even easier, because here we could complete the posterior rexis. We are going forward with the plan of implanting the multifocal IOL. In this case, we carefully implant the IOL in the bag. And here in this case, the IOL also helps to scaffold, it acts as a scaffold to hold the vitreous back, and also as a base to emulsify the rest of the fragments without loss of any fragment into the vitreous. So here we were able to complete the case with good visual outcomes. Of course, we have to ensure that there is no vitreous in the AC by staining with the triamcinolone crystals. This is another case where the pupil was very small, and while emulsifying the fragment, we saw that there was the fragment was going behind and behaving abnormally. So we again put lots of viscoelastic, and also in these cases we have to put visco under the fragments, and preferably bring the fragment in the above the iris, and inject lots of visco in the retrocapsular space also, so that the vitreous falls back. So here again we are attempting scaffolding the tear with the IOL. We are placing the IOL here in the sulcus, and the fragment is then under the fragment. We carefully place the lagging haptic in the sulcus first. Now we can easily emulsify the remaining nuclear fragments without chances of loss in the vitreous. So these steps can be performed only when you're sure that there is no vitreous prolapse already happening, because if there is vitreous in the AC, then we cannot attempt these steps. So another case of an intumescent white cataract, where Argentinian flag sign is a known complication. There is a sudden radial extension of the initial prick on the capsule. So in such cases, again, we do not need to panic. We can attempt to create a round capsular excess from the tear, so that during the rest of the steps during cataract surgery there is less chances of extension of the tear post equatorially into the posterior capsule. The trick is doing phaco very slowly with slow parameters, but as this was a soft cataract, during attempting to chop, we realized that there was a double trouble in this case. We also created a posterior capsular tear here, and we realized it in time. We removed the nuclear fragments, and the rest of the cortical fragments we attempted to remove them through the main incision. So key step is to continue irrigating and put lots of viscoelastic, preferably dispersive. And here you can see we are pulling out the fragments one by one directly out through the main port. Then we complete vitrectomy. Here we are using the irrigation cut aspiration mode, and bimanual vitrectomy where we use a separate irrigation is a preferable option in these cases, but we had the coaxial one in this case. Then we complete the removal of rest of the cortical fragments. Without much loss into the vitreous. We ensure there is no more vitreous around the tear and in the above the iris and near the ports. So we cut from posterior to anterior, and then forming the anterior chamber again, we were able to place the IOL here. So all the time we cannot have such positive results. So this was a very hard cataract, and while attempting chopping of the nucleus, we realized that there was a pre-existing, or this PCR was created during hydrodissection, and the nucleus was almost slipping down into the vitreous. We levitated it with MVR, brought it into the above the iris, and attempted to fragment it, converted into an ECC. We expressed the nuclear fragments one by one. Then with partial closure of the incision, following which we started anterior vitrectomy, ensured there are no vitreous strands in the AC. And then we implanted a 3-piece IOL. Here we are, because there was a good anterior capsular support, we are attempting to implant it into the sulcus. So carefully sliding the leading haptic first inside, ensuring that it is in the sulcus, then we can slide the rest of the lens. Placing the optic under the iris and then gently rotating the lens into the sulcus. So in cases where none of these methods work and you end up with a posteriorly dislocated lens, then we have to refer it to a VR surgeon. So here I'm showing a video where we free the lens from the vitreous around it. We need to do a good vitrectomy first, and then extend one of the sclerotomies by a 20 gauge MVR to allow the phacophragmatome to go inside the vitreous. Here we have also injected a PFCL bubble over the macula to protect the macula from phaco energy damage and also from manipulation of the lens fragments over the macula. And in the same sitting or in subsequent sittings, we can put a secondary IOL. Like here we are placing scleral fixated IOL, the CMT Flex. So recently I have shifted all my secondary IOLs to CMT Flex because of the ease of handling the lens. It's a quick procedure and the centration is also very good. So the second haptic comes out, and then we can seal these scleral flaps through glue, or we can also suture it. We can also implant iris fixated IOLs either in the anterior chamber or like in this one, we can fixate it posteriorly as well, behind the iris. So the key points are that we have to identify the tear as early as possible and start a stepwise approach. Managing vitreous is most important to avoid posterior segment complications, and IOL implant should be attempted only if good capsular support is there, and refer to the VR surgeon as wherever it seems necessary. Thank you.
Thank you very much, Dr. Anurag, for the wonderful presentation. And this is the gambit of different videos which we have shown, different situations you can come across in your clinical practice. And posterior capsular rent is one of the very serious complication which we can come across during our cataract surgery, phaco surgery. And how you manage the posterior capsular rent is very important, because it's not like we do not get the posterior capsular rent, we all get the posterior capsular rent. But how you manage it is very important, because you can give a 100% result to the patient even after the posterior capsular rent. And Dr. Bharti?
Yes, sir.
Yes, sir. Mobile chhod do. Any comment?
I think he has actually dealt with both the posterior capsular rent and the flag sign, Argentinian flag sign, very well. And the most important thing is to manage it, do not panic, and be peaceful at your mind, so that there is, you are not in a hurry to do it, and then probably in all the cases you will be able to manage it. Whatever is there, I think it can be managed. We are all very experienced cataract surgeons, so these are the small issues which keep on coming in. All the surgeons, all of us face these issues. So I think the most important thing is keep your peace in the mind, and that probably is the crux of the matter.
Thank you, sir.
I think again, first thing is you have to recognize it early.
Yeah.
So early recognition helps you a lot. Even the flutter sign is very good. If you were showing the white mature cataract, the flutter sign is very good. You can know the whether it's extended to posterior side or not. So you can continue or not to continue, you can decide with that one. And of course the tamponade with visco and even with the lens is a very, very good option in these cases. You have shown it beautifully. So whenever you get it, first thing you have to relax and take your time, pray in all languages if possible, and then start your next step. The visco, putting a visco is immediately, I think that's the most important thing, what he has shown as there. Put the visco immediately and then take your time and start what you want to, how you are going to manage these cases. Excellent presentation.
Depending on the demands of the patient, we have a few old patients who have undergone aphakic cataract surgery many years back. So we have some patients who usually come for a secondary IOL. So visual act, definitely, because the patients who are dependent on aphakic glasses, when they get freedom from that, then definitely it gives a good visual outcome. Secondary IOL. In some very old surgeries where before pre-phaco times, there is in some patients where there's an iris loss or there's a very high astigmatism, corneal astigmatism. Yes, few patients, especially to remove the remnants of the capsular bag, because otherwise the secondary IOL will not center properly.
Thank you.